Okay, Chapter 6, Health Services Financing. This is a big chapter in the book, but it can be broken down a little bit easier if you break it down into pieces when you're reviewing this and reading it. This is not going to be a chapter you can sit down. Maybe, well, I'm speaking for myself. I couldn't just sit down and read this and grasp it all. I had to walk away a couple times, come back to it, break it down into sections by the headings and the subtitles or whatever subheadings. Okay, so let's jump into this PowerPoint. Objectives are listed on page 217 in the book. They're listed here. Intro, of course, United States healthcare system is very complex. There are public and private financing roles. Insurances overlap sometimes. Insurance financing is shared between employer and employee. Taxes will be raised to provide the governmental health insurance. Other countries like Australia, Canada, the UK, there are single payer systems in those countries. I don't know if what would be better for us if that's something that we could easily debate inside of a classroom, and maybe we'll discuss it in our discussion board. But what we're doing may not necessarily be working well here in the United States. So what could we do better? What could we learn from countries that offer free healthcare? What could we learn from the single payer countries? And how can we maybe blend and meet everybody's needs? Which is definitely a theory. I don't know that would ever work. Okay, but it would be fun to try to figure out if it's not costing billions of dollars. All right, role and scope of health services financing. So financing, well, let me back up. Like the book said on page 219, there will always be uninsured people in America for various reasons. They list some of them there. With the evolution of health insurance and it being more affordable and covering more items, we use it more. So for example, myself, would I go get my teeth cleaned twice a year if my insurance didn't pay for it? Probably not. I probably only go once. My eye exam that I get every year, would I go to that every year if my insurance didn't pay for it? I don't know that I would if I didn't need to. You see what I'm saying? So when we have health insurance, it leads to a higher utilization of the insurance, which then can create a moral hazard. And not that it's a bad thing morally, just it's a hazard as far as having resources available, affordability of certain tests, diagnostics, and etc. Healthcare services and technology proliferate when services are covered by insurance. Again, when you have it and you can get it at a discounted rate, you will use it more, and that is especially true in healthcare. All right. So I have this circled for me as an example. Employer financing for dental insurance spawned the growth of dentists and dental hygienists. Yes, absolutely. 10, 15 years ago, you did not see a dentist on every corner in small town America, but you do now. I can speak for the small town I live in. We have 1, 2, 3 stoplights and probably 10 dental offices. So small town America, yes, with the invention and advancement of dental insurance, yes, there's a lot more need for dentists and dental hygienists because of that, and that's what that's referring to. All right, flip page in the book. Financing and cost. I'm going to flip this slide. So the United States healthcare delivery system, insurance is the main factor that determines the level of demand for medical services. I think that's like the 4th time we've said that. I am not expecting you to grasp this or review this. The P, the E, the Q. Review that, take away what you want to from it. I do not intend on testing or quizzing on that equation. This is not algebra. Okay, the insurance function. The function of insurance is 4 fundamental principles for the purpose of insurance. The risk, you want to make sure you have insurance to be insured in case something were to happen. For the unpredictable stuff and the predictable stuff. Insurance mechanism transfer risk from individual to a group. Members of insured group share the losses. So you would never want your insurance company, privately or governmental, to have 90% of their insurers paying premiums have a chronic illness. That's very skewed. That's off balance. And only have 10% healthy people. That's you know, I didn't say that very well, but you would want equal parts maybe, or maybe even have more healthy people than you do people with chronic illness within your group or within that policy. And page 221 talks about that. It goes into ensure the underwriting. And remember, by the way, underwriting is done by physicians. So I kind of scratched my head at that. But I guess you have to have experts writing these policies. But again, it's kind of a conflict of interest. But anyway, moving forward, plan is a vocabulary word also on 221, insured beneficiary. So we keep going to private health insurance. Let me flip these slides. Health insurance status of the U.S. population 2015. So 9% were uninsured, 49% were employer-based. Yes, that's going to be the norm. Medicaid and Medicare were on here. So Medicaid is more so than Medicare for 2015 now. Good gracious, that's already 7 years ago. Okay, so those numbers have changed obviously over time. Private health insurance, these examples are like United Healthcare, WellPoint, Cigna, Blue Cross Blue Shield, Aetna. That's who our private health insurer companies are. You can obtain those policies personally or through an employer. Now, through an employer should be cheaper because, again, that's a group that is paying those premiums. And, again, hopefully you have equal healthy people with equal people with chronic diseases, or maybe even, like I said before, more healthy people than people with chronic diseases. So the book goes in page 222, talks about premiums, risk rating, cost sharing, the deductible. This was mentioned also in the book. Let me see if the slides go over this, the example. So yes, if you have a health insurance plan, you typically have premiums, cost sharing. This deductible is what I was looking for. It does not go over. So in the book, it mentions high deductibles of being like $1,000. Well, this book obviously was published in 15, 16, whatever. It was actually published. My personal deductible is now $3,000. So the cost of healthcare continues to rise. And I still pay good amount of premiums every month for my health insurance. But my deductible before insurance pays is $3,000. I have to spend $3,000 first. So obviously, I am healthy. I do not spend that type of money every year, but that would come in handy if I were to ever have a trauma or need major surgery, or that's that risk that the risk rating that insurance is, the terminology is referring to. So that's why I still pay for my health insurance. Even though I'm a healthy individual, an accident could always happen, or a sickness come up that was not planned. Okay, page 224 ends by talking about covered services. What are the benefits? Every insurance policy is different. Some policies cover mental health, some do not. Some cover maternity, and some policies you have to pay extra for that if you're in age-bearing years for a female. Types of insurance. We have group insurance, we have self-insurance. Self-insurance is not that common in our area. It's more common out west, and the book it talks about Kaiser. And Kaiser was a company who, instead of buying a group insurance policy, they did their own. But there's not many like that. The movement towards this self-insurance by large employees, it was brought on by governmental policies. They actually got a huge premium. They were exempt from a premium tax when they did this. So it was a way for that company to it was a way for that company to save money. All right, page 226, managed care plans are mentioned. High deductible health plans. This is very, very popular now. So not my plan that I was referring to, but companies offer one step further. You can opt in a health insurance option with like a $15,000 deductible, and your premiums monthly are drastically reduced. So instead of paying $300 a month, a person who chooses that high $15,000 deductible may only pay $75 a month. That's great if you're one person. If you have a family of 5, 6, 7 people, imagine spending that $15,000 per person, reaching that deductible. That's a lot of money. So those are different things to consider when you have these health insurance plans in front of you. And don't ever sign up for a health insurance plan without reading it literally like word for word, knowing exactly what is covered, how much it's going to cost, etc. So short-term gap coverage, this is COBRA, in the event that someone quits their job, gets fired from their job, they have however many months of coverage that they have to pay for, and you do pay more for COBRA, you do pay more for gap insurance, but at least you have health insurance until you get another job. Medigap is mentioned on page 227, doesn't cover extended long-term care, vision, dental, etc. Trends, we start talking about trends on page 228. Trends in private health insurance. The Affordable Care Act mandated that employers with 50 or more full-time workers had to provide health insurance. Well, that, and if they didn't, they got a penalty. So I think the government thought they were going to make money on that, but 93% of employers in the United States have less than 50 full-time employees. So think about that. And I would love to know those numbers for 2022, but it didn't take care of the problem as much as they thought. Because again, so many employers in the United States have less than 50 full-time employees. Okay, I'm going to flip the page in the book. Trends in utilization cost. Here, cost sharing, we talk about that deductibles, the co-payments, the co-insurance. So as a healthcare consumer myself, I pay my premium to even have the policy. Then I meet my deductible. Then I also pay my co-payment. So if I go to a specialist like a dermatologist, I pay $25 instead of $15. I pay $15 at my primary care, on top of meeting my deductible and on top of paying my premiums. And it's just expensive. It is expensive to be a healthcare consumer in the United States. There's just no way around it. It just is. All right. This table is mentioned here. Oh, I am already at 12 minutes. All right, let's get rolling. Okay, this table is great. Great information. Private coverage, 6 main ACA provisions. I'm not going to read those to you. My favorite one, when this came about, the Affordable Care Act, is that they could not deny people coverage for pre-existing conditions. That was a huge win with the Affordable Care Act. Please read the other ones. They are important. I'm just going to flip through these kind of quickly now. Public health insurance, Medicare. I try to remember it this way. Let me flip to the next screen because it's a bigger word. Okay. Medicare, care for the elderly, care for the disabled, care for those with end-stage renal disease. That's how I have to remember Medicare. And your book goes into Part A, Part B, C, and D, what they cover. There's several pages there. There's even exhibits, Exhibit 6.3, Exhibit 6.4. There are out-of-pocket costs with Medicare. Again, this is just expensive. It's expensive to be a consumer in the healthcare world. So stay healthy. We have to manage our weight the best we can, limit processed foods, limit alcohol, smoking, etc. All right, Medicaid. The way I remember this is aid. So like financial aid is what it reminds me of. There are 3 categories that this covers, and it's on page 242, the bottom left-hand side. The people who are eligible for Medicaid: families with children receiving support under the Temporary Assistance for Needy Families program, people receiving supplemental security income, and children and pregnant women whose family income is at or below the federal poverty level. So that's who qualifies for Medicaid. And again, that is a financial burden relief type of thing, and it is insurance, but again, there's issues with Medicaid, and you guys can read all about that. The main problem is the lack of reimbursement for providers. So what you find is if there's 10 doctor's offices in your area, only 1 may take Medicaid because they do not pay well. They just don't. Trying to save money like everybody else. Flipping over to page 244, Medicaid enrollment and spending, Children's Health Insurance Program. There's even a health insurance program for the military, TRICARE. There is the VA has their own entire medical administration group, hospital services that they provide. There's Indian Healthcare Service on pages 246 to 247. You can read about that. We're going to go lastly here to this payment function. So the payment function, there are three parties, if you will. So one being the patient, you pay for your healthcare services. Two, the provider is part of that payment function. And the third are third-party payers, which are the insurance companies. So it has a couple of layers here. Fees for service. This is the oldest method for getting payment. And so what happened was when you would go into a hospital or a doctor's office, the services were billed one by one and itemized. So you could get billed for every little thing they did, and you get multiple bills. Maybe if you go for surgery, you get a bill from the hospital and the anesthesiologist and the lab. Oh, and the surgeon was going to bill you too. So the main problem with the fee-for-service arrangements is that providers have an incentive to deliver additional services that are not always essential because they got reimbursed based off what they billed for. Then came along bundle payments. It's like package pricing. You get, whatever service you asked for, you get that one payment no matter what happens. Medicare they pioneered the bundle pay mechanism trying to save money. So for example, if you came in for your appendix, you got paid for the appendix surgery. Maybe if that patient acquired an infection, or maybe it wasn't the appendix, there was additional charges incurred, Medicaid wouldn't pay for it, or Medicare, I'm sorry. Okay, so resource-based value, you can read that. Value-based reimbursement. This is where we are. Let me back this up. Where is it? Oh, value-based reimbursement. This is where we are currently in our reimbursement payment cycle. You, as a provider, hospital, skilled nursing facility, rehab, you get paid based off of outcomes and patient satisfaction. It is the way it is. Okay, I'm going to keep going. I just want to make sure I don't miss anything in the book. So managed care approach on page 250. There are three main approaches to managed care. The preferred providers are ones who negotiate discounts on their fees. Capitation is the provider is paid a set monthly fee per enrollee. And the third is MCOs that employ their own physicians. Then that page goes into cost plus reimbursement. It was a traditional method used by Medicare and Medicaid. But now, because the reimbursement method rates after evaluating the costs retrospectively, this mechanism is broadly referred to as retrospective reimbursement. So that this is after the care has already been billed. So this is what kind of keeps the cost of the facility going, if you will. So, but now we're more on page 251, you pay for services before they're delivered. So if you come in for outpatient surgery, sometimes even if you go to the emergency room, if it is not life or death, they're going to collect your copay before you're even seen by the doctor. And the same thing for surgeries. You will pay for your surgery, your copayment, co-insurance before they even start the surgery. All right, so let me try to figure out where I am in the book compared. I'm sorry. Bear with me. We're still talking about payment function. All right, bottom of 251, DRGs, diagnostic or diagnosis related groups. This is that group billing. So the bottom of 251, the MS DRGs, that's medical severity. So that is based on how severe the acuity is, or how much it's going to, how hard or how much is it going to cost to take care of that patient. The MSDRG carries a relative weight that reflects how costly it would be to take care of the patient. I just said that. All right, page 252 continues with long-term care hospital payment system. That is very different than inpatient. The outpatient prospective payment system, again, is different. The page 253 under case mix methods. The case mix method is used for paying skilled nursing facilities. This is an instrument used for comprehensive assessment of each patient. It consists of a core screening elements used to assess clinical, functional, and psychosocial needs of patients being admitted. So skilled nursing facilities can do so many things, and you have to have a way to measure and determine how much you're going to pay for that patient to be there and how long they can even be there. Those type of things dictate that. Some insurances will pay for 30 days, but not 31 days. Okay, national healthcare expenditures. You guys can read through this for information. I'm not going to read it to you because this is a long video. Current directions and issues. Yes. Just review the end. And of course, fraud and abuse is a big issue with insurance. I'm not going to hold you to these figures, but review it for your information. And there's our summary. Okay, please let me know if you have any questions about this chapter. Again, it was a big one. And I'm here if you need anything. Thanks.